we can continue to work as dermatologists and oncologists and our teams in order to continue to refine best referral practices and even, adjust clinic practices so that some patients, can be managed by the oncologist and not referred.
That's Dr. Emily Smith with St. Louis University. We'll hear more from her later in the show. Welcome back to Cancer Buzz. I'm your host, Summer Johnson. Collaboration between dermatologists and the cancer care team is critical for treating patients with advanced non-melanoma skin cancers. But care coordination can be a bit challenging in community settings with fewer resources. Today's guest is here to discuss what good care coordination looks like, with a focus on early referral and identifying high-risk patients. Dr. Emily Smith is an associate professor of dermatology at St. Louis University in Missouri.
I think probably one of the biggest barriers that we face are disconnected healthcare systems. Specifically, many dermatologists operate in outpatient clinics that are not necessarily affiliated with a larger healthcare system, so operating more independently, and access to those tertiary care facilities can be quite challenging without a direct contact. So even if a patient is identified as high risk, getting a patient scheduled can sometimes be quite challenging if the referring provider is not familiar with the institution, or even if they are, sometimes there are barriers such as call centers, phone numbers that don't directly link to referring providers. Things get lost in the shuffle. I think that certainly is one of the biggest barriers. And that goes for, referral to surgical specialties and then certainly referral to oncologic specialties as well. There are some communities that have really well-developed networks within a more of a private practice scheme, but I think those are few and far between. And in my experience, that has certainly been one of the substantial barriers I have observed.
How is oncodermatology different in the community setting versus larger academic centers?
Well, I firmly believe that oncodermatologic services are best provided when the dermatologist is in very close proximity, if not directly within a cancer center. And so, again, many community dermatologists practice in, their own buildings, separate from a cancer center, physically separated from a cancer center, as well as sometimes organizationally separated from a cancer center. And so for oncologists, certainly oncologists who are not practicing in a big academic center, who have a patient who has a dermatologic toxicity, finding a dermatologist that not only can accept their patient, I know many would say, yes, of course, we'll see the patient same day, but in a geographic location that's easy for that cancer patient to actually get to, it gets really challenging. And many of these toxicities require, urgent evaluation so that patients can continue therapy. Having a dermatologist in an academic setting or embedded within the cancer center truly facilitates that rapid consultation. You can see the patient before they've been, treated. You can make a very quick assessment and determine the best course of care. I do think it's really nice as well from an academic collaboration standpoint that we can continue to work as dermatologists and oncologists and our teams in order to continue to refine best referral practices and even, adjust clinic practices so that some patients, can be managed by the oncologist and not referred. So I do think there are definitely benefits to having a dermatologist within a cancer center, and that usually does occur in these bigger facilities. I know many, many, many community dermatologists are, very much expert in managing these toxicities. It's just an issue of the challenges of getting the patients in, via scheduling and geography.
What does successful diagnosis and referral look like?
So successful referrals, I think, start with identifying the high-risk patient. And I know this has been a major push of mine as well as larger organizations to help increase awareness around what constitutes a high-risk patient. And, those definitions are dynamic and changing. And as more and more treatment options become available, patients who are defined as high risk, that may change as well. So I think that the most successful referral starts with identification. And then the referring provider having a direct connection to whom they should be referring to. That provider also needs to know which specialty, to send to. So not every single patient with a high risk tumor is going to go directly to the same provider. I do think that some of the more successful referrals from private practice into a bigger system are funneled through a gatekeeper. And at that bigger system or at that receiving office, it can be a coordinator, it can be, an RN or a higher level nurse or advanced practice provider. And that at least provides referring physicians with one person to contact. And then that person can accept all of the data and piece together things in an expert way to make sure then that that patient is filtered into the appropriate specialties at the tertiary care facility. Step one, though, is identification. Step two is knowing where to go. And those are, again, big gaps and barriers that we are continually working to address.
What are some consequences that can come with a delayed referral?
The first one that comes to mind that is unfortunate are, emotional stresses to the patient. Often the patients are provided the diagnosis immediately. Many receive these diagnoses, pathologic diagnoses, in real time through their patient portals. And so at that moment begins the patient journey with this cancer. Not all of the times will the patients be aware that it's a high risk cancer at the outset, but very soon they're usually notified as such. If a patient is not referred promptly, that certainly can increase their emotional distress. More importantly, if, for example, a patient is not identified as high risk at the outset and undergoes a less aggressive treatment plan, it's quite possible then that the patient will have an adverse outcome, that it will at that point prompt referral to the tertiary care facility and may end up resulting in more extensive surgery and or medical or radiation treatments than may have been necessary if they had been referred at the outset.
Are some patients at higher risk of recurrence?
So certainly the patients that have, and when we're talking about either locally advanced basal cell carcinoma, squamous cell carcinoma, I think they sort of fall into a similar category. Bigger tumors, rapidly growing tumors. With respect to squamous cell carcinoma, we know tumors that have high risk growth features under the microscope. There are characteristics of the tumor that certainly can increase a risk for local recurrence. A patient's immunocompetence, so being immunosuppressed, can absolutely increase one's risk for local recurrence. And then, of course, appropriate management at the outset. So an inadequate or insufficient treatment plan, maybe if we, just excise a lesion and then don't offer adjuvant therapies such as immunotherapy and or radiation therapy, depending on the tumor, that can increase the risk for local recurrence as well.
How can the current staging system better facilitate faster diagnosis and referral?
Yeah, so I think with respect to cutaneous squamous cell carcinoma, this is an area in which our NCCN guidelines and our staging systems could hopefully be revamped to facilitate a more streamlined referral process for these patients. And so I think using melanoma as a good example, we have very well-defined staging criteria and very well-defined guidelines, and the care pathways for these patients are, again, also very well-defined. And prompt and, thorough care is usually facilitated quite easily. With squamous cell carcinoma, I think a consistent staging system is first and foremost. Some physicians use Brigham and Women's criteria as their staging system. Others will use the ACCC system. Many of us use both in combination, but as a result, you end up with a patient who has two separate stages. Our NCCN guidelines don't give us definitive care pathways for a Brigham and Women's T2B squamous cell carcinoma, for example. Then, if we have a patient who lands in that tumor stage, as a multidisciplinary group, we have to decide what the best care plan for that patient is. So when you're in a large tertiary care facility, you're working within a multidisciplinary system, that's a little bit easier to determine a care plan for those patients. But if you're working in isolation in a community clinic without colleagues to discuss this with or without defined care plans, then that can be quite challenging. So I do think we have substantial room to improve. And I know that we are working diligently as a specialty, and I should say collaborating specialties, to refine those care pathways based on staging and data, but we're still not there quite yet.
What advice would you give to community dermatologists who are looking to improve quality of care for these patients?
That's a great question. I think that as a community provider, it is always important to do your best to stay up to date on the literature. And there's so much out there right now, it's impossible to read through every single journal that comes out every single day. And so there are really nice email listservs that providers can sign up for that will provide updates. And it's through those routes oftentimes that new and emerging data and recommendations will be displayed. Specifically, the American Academy of Dermatology does post guidelines for the care and management of different cancers, cutaneous squamous cell carcinoma, basal cell carcinoma being two of them. And they are updated on a cyclical basis. And so those are great guidelines to just ensure, every couple of years that they are reviewed and that current practices are following those guidelines. I also think that participation as much as possible in continuing medical education activities in the arena of skin cancer, as well as attendance, either virtually or in person at our annual meetings, also just makes you available to all of the new and emerging data that is out there.
Thank you, Dr. Smith. You can head to the show notes for more information on advanced non-melanoma skin cancer care coordination. This episode was made possible with support from Regeneron. We hope you enjoyed this content today. Make sure you're following the show on your favorite podcast platform. Just search for Cancer Buzz and tap the plus sign or the downward arrow. We'll see you next time. For the Cancer Buzz team, this is Summer Johnson.
This show is a resource of the Association of Cancer Care Centers.